Great, thank you very much. Well, you did a great job with my name. I appreciate that. I know. Just a few gambles there. You're never sure. So I get 20 minutes. I apologize. So we'll try not to use the whole 20 minutes, but I think it's really important for everyone here to understand how this really controversy impacted our peripheral vascular field, how we've tried to rectify and clarify some of the inaccuracies in the data and close some of the gaps that remain, and how we've made a lot of progress in resuming practice, which really should be a drug-first approach for peripheral vascular intervention. And these are my disclosures. So I'd like to just paint the objective. So we're going to just talk a few minutes about the importance of peripheral drug-coated devices. And I think Will did a wonderful job really with his talk, setting this section up. And then I'm going to talk a little bit about why this controversy came and why we think it was more how the data was analyzed and a true relationship. So I'd love to start with just a case. This is a gentleman I've followed for quite some time. He had a history of a bypass surgery on the right side in 2007. And when I met him, I had really been establishing my program, and he had come in and he was actually using a cane, but he was so numb in his foot he couldn't ambulate, and really lost touch with his vascular surgeon who did his original bypass, was still smoking, didn't know where to go. And you can see his PVRs here are pretty flat from the calf down. Excuse me. And so we brought him to the lab, and this is his common femoral. This is a wimpy profunda. This is the ostium of the SFA, and this is the hood of the graft. And you can see the graft coming down nicely, so it's a fem distal SFA or P1 graft. And you can see it insert here, and then you can see why he's having that numbness. There's that complete occlusion here. And so these are always tricky to fix. It's an older graft. You have to choose whether you want to try to preserve the graft or go after the native. Here it's a very long occlusion, so the hope is we can preserve this graft. So you do this really carefully, and you can see that angle here is not advantageous, but you also have the problem putting a stent here. You don't really have a lot of landing zone for a stent. You're down now close to P1 and into the popliteal space, and so you really try to avoid stenting here. And so we were able to get through with a funky wire, get a balloon actually to deliver, and then did a drug-coated balloon, and this was our outcome here. So I followed him very closely after this. His symptoms completely resolved. He stopped smoking. He got his life back. And he ended up having some increased velocities on the surveillance imaging at his proximal graft. So I brought him back just to make sure we understood what was going on. This was now 3 years later. And we did run-ups again. And you can see from 2018 to 2021, again, just a balloon with drug on it was able to maintain that patency there. That wasn't the issue. And so, I just like to start with this because it tells you why this therapy has changed the natural course of peripheral vascular disease. This would not be the expected outcome with an uncoated balloon, okay? And so, I always start with these data to say, why are we even having a conversation supporting drug-coated devices? Well, these are randomized trials that were meta-analyzed. So you take all the randomized trials, put them together into a pool, and you'd say, okay, we know that there's small studies, a couple hundred people here. Now, if we meta-analyze them, we've got about 1,000 patients. And what happens when we put them all together? We can see at least at 2 years that if you use a drug-coated device, a drug-coated balloon in these trials, you have less target lesion revascularization and greater primary patency. And if you put that up against other devices, in blue here is that balloon angioplasty, the TLR rates are as high as 35 to 40% at 2 years. You can see bare metal stents, the traditional ones, 25 to 30%, and you start moving into drug therapy, you're now getting into 15 to 20% target lesion revascularization at 2 years. So much smaller rates, much better patency when we use drug on our devices. And when you look at the guidelines, this is from SCI, one of the interventional societies, drug-coated devices got a real green light, clearly indicated for definitive treatment for most indications. So when they come onto the market, again, this is a newer field. The first drug-eluting stent or drug-coated stent was 2012 in the US. Drug-coated balloons weren't approved until the end of 2014 and really started to become available in 2015. So we've been working with balloons and uncoated stents for a long time, obviously surgical revascularization for appropriate patients. But look at what happened to practice. So this is after approval, and you can see here that balloons kind of stagnated, drug-eluting stents came up, but drug-coated balloons, this is the number of devices being used, shot up from nowhere to now being the predominant therapy for patients with peripheral vascular disease. And again, this is vascular surgery data on the right, showing how even vascular surgeons who do both combination of endovascular and open procedures moved away from drug in blue and orange to quickly to drug-coated devices in gray and yellow. So this is my paint the premise of why we need to think about these controversies seriously. So we always talk about the first big paclitaxel controversy was that we lost reimbursement for these devices at the end of 2017 and they weren't being used. So when we used to have these conversations, I get invited to speak about how we get people to use more of these devices because they're the appropriate device for a patient, they're the indicated device for the patient, and cost shouldn't be the limitation for a patient getting these devices. And then we moved quickly into our controversy. And again, we're going to see now how these rates changed. Now, this is in the reimbursement period, so we stopped using drug-coated balloons as much just because reimbursement got pulled away. And later, I'll show you the rest of this figure that I'm unveiling what happens after the meta-analysis showing harm with these devices. So this is the headline from the meta-analysis published at the end of December 2018. So for a lot of us, including a lot of the course directors here, we were on this big text chain and everybody came out and said, did anybody see this coming? And most people were like, oh, this is a smaller journal. It's not going to make that big a deal. We're going to be fine. But what did this meta-analysis show? So what they did was they did something called a summary level meta-analysis. That means that all they can access is what has been published in a paper or presented in an abstract at a conference. So they don't have the actual trial data. They have the summary level data. And what they try to do is put all that data together, and they want to look at death. Now, the problem with looking at death in these studies is nobody has designed a trial to look at death for drug-coated balloons. We're looking at patency, we're looking at amputation-free survival, we're looking at improvement in claudication symptoms. We don't think that drug-coated balloons are saving lives necessarily. That's not why we do these procedures. So death is kind of irregularly reported and primarily a safety event at 1 year. So you'll see what happens because of this. So at 1 year, they had 28 randomized trials because most trials had 1 year mortality as part of FDA approval, and they showed no evidence of harm. Somehow between 1 year and 2 year, people are dying in this study. I can't explain it. We don't really have a lot of interventions that can kill 3.5% of people between 1 and 2 years. So that was already where I raised a red flag is how is everybody looking really good at 1 year? And then we lost 3.5 of 100 people to paclitaxel toxicity. And so, you can see here that now only 12 trials actually reported mortality at 2 years. And a lot of these devices are not available in the US and were not ever FDA approved. These were balloons and stents. So they weren't just one type of device, it was a combination. And you go through it now, 4 to 5 years. There was only 3 trials that somehow put in death data at 4 to 5 years. It was only 860 patients. And you got this really remarkable 7% increased risk of death. I mean, again, that is like the worst toxicity you can get from a treatment. We don't see that when we give chemotherapy to patients where we think they pass away from chemotherapy-related toxicity. I mean, this is really unusual. But this is the text chain again. We're sending around gifts at this point saying, come on, this makes no sense. But we did not see what happened, what was coming next. So pretty much within weeks, randomized trials looking at these devices were halted, especially in Europe where they're much more conservative. And then the FDA came out in January and said, we're taking this seriously. This is a big problem. So this really was, a change in what we had been experiencing in the peripheral vascular field. We never had a controversy like this. And we had 10 years of momentum getting these devices on the market, getting some reimbursement at some point. And all of a sudden we're back thinking, are these the right treatment devices for our patients? So we, at my research group in Boston, we kind of came out in front with some data that we had available. And what we were able to do is we work a lot with insurance claims data, in particular Medicare. And so that's kind of what our group's known for. And what we realized is I can tell everybody in the US who's got a drug-coated device during certain time periods. I could also tell everybody in the US who died because Medicare really wants to know if you died. They don't want to pay you if you're not alive, right? They don't want their sons and daughters getting that money. And so we had a really good opportunity here to say, well, let's just look at the natural course of people who receive these devices in the US and see what happens. So within weeks, we had these data up online showing again that we couldn't replicate the harm signals seen in that study. On the left here are drug-coated balloons and stents. Yellow is drug. You can see survival is better for drug than non-drug. On the right here, these are drug-coated stents versus bare metal stents. And again, showing really nicely that there's overlapping curves, no evidence of harm in this thousands. Remember, it was 860 patients in that 4 to 5 year mark in that meta-analysis. And so we've done a lot of work with this. We went to the FDA with this. And we went to the FDA and we said, okay, what are we going to do to resolve this scenario? And they have to say, well, we usually run a randomized trial. I said, okay, well, what does a randomized trial look like? And so we had them run the numbers, and they came back and they said, we need 20 to 40,000 patients to be treated with either a paclitaxel device or non-paclitaxel device to power this for death at 3 to 5 years. I mean, we run 800-person trial. That's a huge peripheral trial, as you guys know. So it was quick that everybody realized we weren't going to be able to solve this with the randomized trial. We would pretty much end this whole, whole field. And so the FDA put out this letter that maintains right now that drug-coated devices should be used for patients at high risk for restenosis. But we've really fought back. We said, let's generate some data. We have some trials that I'm going to show you in a moment. We have some real-world evidence. Let's fight back and really demonstrate to the FDA that it's hard to believe any of this. It's hard to believe it anecdotally, just from a clinical cap, and then also from a research side. It's hard to replicate this harm signal in a really flawed study. And so again, I've been showing you this curve. So 3 sections here. The early phase of drug-coated device adoption, when reimbursement changed, and you can see drug-coated balloons tailed off. And then look at what happened after that Katsanos, we call it meta-analysis. Complete drop in drug-coated balloon, drug-eluting stent. $250 million industry was pretty much decimated by this. So we've been working really hard to generate that data since August 2019, which was after that FDA letter, to come back and say these devices are safe and important for our patients. I just want to show you guys a few studies just so you have them in your pocket if you're ever asked about this, because it's really important to know why we've seen a resurgence in use of drug-coated devices because of the data that's come out since this controversy was presented. So the first was a study called Voyager, and hopefully you'll hear about Voyager. Either you've heard it this morning or you'll hear about it today, but this is a really important trial that was going on looking at medical therapy after a peripheral intervention. And the goal was either to put them on a low dose of an anticoagulant, Xarelto, with aspirin plus or minus Plavix versus standard of care, which you guys have seen, which is usually dual antiplatelet therapy. In that study, they had a number of patients, 4,300, that underwent an endovascular treatment and with either drug or not drug. So you have a really nice randomized trial where they've collected exactly the device used. They had full follow-up for mortality. And you can see in these overlapping curves that there was no evidence of harm between those treated in yellow with a non-drug-coated device and blue with a drug-coated device. So this is from a sub-analysis of a randomized trial. This study, SweetPad, was a randomized trial that was halted. Remember I showed you those little headlines? This one was halted. I'm going to look at the real-world efficacy of drug-coated balloons in Sweden, and they have a really robust trial network there. So they wanted to randomize patients with either CLI or claudication to a drug-coated balloon or standard care, and they wanted to see how well it performed in a real-world population. This got halted, and then once we went through some regulatory pathways, we were able to restart the trial, and it was never meant to look at death, but they were able to look at death. So they said, okay, we'll do an interim analysis for death. So now people are actually randomized to drug-coated device or not drug-coated device. So it's not that 20,000 person trial that the FDA calculated, but we get a good couple thousand patients here. And you can see out to about 4 years, again, curves are overlapping. This was in the New England Journal of Medicine in the end of 2020. And curves are overlapping, showing no evidence of harm, at least to 4 years with a drug-coated device. So you'd think that would be enough to put this to rest, yet I'm still here talking about this too. We went back in that Medicare data, and the FDA called me and they said, listen, great presentation. You did a wonderful job. Can you make it a lot bigger? Can you add in these outpatients? Can you do this, this, and this? And I said, okay, let me go back and we'll design something. So we literally put together a huge statistical plan. We sent it to FDA. The FDA made edits. They wrote it, sent it back to us. They said, great, do this study. And so we presented this study as a late breaker at the American College of Cardiology last year, and we had to update it at our conference Sky this year. I'll show you. But now it's that same kind of data I showed you before of the real-world Medicare patients that you guys are all treating every day are in this study. And you can see now we have data out to 5+ years, and there is no difference of harm or of survival with drug-coated devices, not drug-coated devices. And you can see all these different risk groups, people with critical limb ischemia, people treated outpatient, inpatient, sicker, healthier patients. And when we looked at this early in the year, we unveiled out to 6.5 years. We, again, can't find any evidence of harm. We have 32,000 patients that had more than 5 years of follow-up. I showed you that meta-analysis at 860 patients that destroyed the entire market. So I just want to reaffirm that we have a lot of really supportive data that we cannot replicate anything seen in that meta-analysis. One last data set that I think is important is this is from our Veterans Hospital, and they were actually able to look at different causes of mortality, cardiovascular, diabetes, malignancy, infection, anything you can theorize as a mechanism for death in this study, and they found no evidence of harm. And again, when you put this in an updated meta-analysis now, I put these red bars here because now with more data that's available out to 5 years, less missing data, we're able to show again that there is really no evidence of harm with drug-coated devices. So I'm just going to tell you my pearls about what I got from this trial before we wrap up here. And this is, early again, I gave this talk actually to PK's group for just a kind of a cath lab journal club. And so, everybody always asks me, so what is the truth, right? And I can give you my best guess here. I want the truth too, but I think I know what went wrong here. So one big thing when you guys are looking at, really looking at studies is you got to get into the methods a little bit. I know that's a little bit foreign if you haven't spent a lot of time training to dissect, we usually look at abstracts, we really got to dissect papers. And I kind of showed you early on, but a biggest flaw here is if you put a whole bunch of groups together and someone is missing, so this happens in randomized trials all the time, someone's missing, you have to be able to account for that. You can't account for that if you're just taking abstracts and studied and published papers and not getting the raw data. So we found that up to 30 to 40% of patients were just missing from these studies. And when they're missing, they count as alive. That wasn't actually true when you go back and you find them and you put them back in the study. A good proportion of them had died. And a lot of them were in the uncoded group because people who are getting drug-coated devices tend to be at centers that tend to take a little bit more care of patients, had more follow-up and whatnot. And so there was a lot of what we call ascertainment bias, or understanding why people were being coded as alive when they really had died. We also have to think about what goes into a study. You can't take two incredibly different people in two very different studies with two different endpoints and put them all into one study and say, we're going to get a really reliable signal here. So to start, we don't really like combining claudication and critical limb. Those are two different disorders with two different intents, right? We're thinking about amputation in one and quality of life in the other. The other thing is we don't like to combine stents and balloons. Those are very different devices with different implications. And so, this is a really big flaw when you go back and I did my master's at Harvard in statistics, and this is like day one is don't do this, Next thing is causation, and I think this got brought up really nicely by Will, is we need to have a theory of why something is causing harm, right? We need to understand, well, we are worried that paclitaxel in the body is doing X. Okay, tell me what X is. So X is it's forming aneurysms and they're getting amputated, and then they die. We're going to say they going into the lungs and causing infection or cancer. We looked at everything at the FDA panel. We had hematologists, oncologists. We had everybody up there. The oncologist said we give 20,000 times the dose to pregnant women who have breast cancer, and they don't die 3.5% more in 2 years. So, we really needed causation. We never got it. And then really where I came in is we can't reproduce this harm signal. And I tried to convince you guys that of today, and I'll show you a summary slide, but we can't find another data set that shows harm. And even the original data set, when updated, is no longer showing harm. So there's something wrong with how that original study was done. And lastly, I just want to remind you guys that randomized trials are not perfect, especially when they're smaller, but even bigger. Sometimes people make it into one arm at a greater proportion than another arm, and that happens. And I could give you some examples if we had more time, but this is a theory that randomized trials are always perfect, and they're not. And so again, you have to go into the data and understand them. And again, this is a really important concept here. So I'm just going to conclude that my feeling is this was a very flawed study, and that we've demonstrated through a number of studies that we have not been able to replicate the signal. And all of you know how important that this device is for our patients and for long-term care. And I hope that you guys understand that there was a mistake here when that paper was published. I think that there has been a little bit of a delayed response from our regulatory bodies who could be doing more right now. And we've been working with them on it, and hopefully you'll hear more soon. But I'll just end on this slide. This is everything I presented to you. So it's a lot going on here, and I just want you to focus here. This is the meta-analysis that started with that Jaha paper I showed you. And every time you added in that follow-up data that's a little bit longer, all that missing data I mentioned, now you get to a signal that's no longer significant. This is still about 10% people missing, but no longer significant. On the right here is all unique data. So I showed you the randomized trial, the sub-analysis, all the real-world data that we've been doing. No one has shown a harm that we saw in that original meta-analysis. So I'll leave you on that note. Thank you very much. This is my contact information. If you have any questions, you want some slides or any of these papers, let me know. I'm happy to send them to you. Thank you for paying such great attention, and I appreciate it.